This episode is brought to you by the American Urological Association. Today's episode is all about what you can expect from our newly designed full-day hands-on skills trainings at AUA 2025. Among the skill sets of MRI interpretation, segmentation, fusion-guided transperineal prostate biopsy, and transperineal spacer techniques, attendees also receive access to a library of on-demand virtual didactics straight from the experts. The early bird deadline for hands-on skills trainings ends March 7th. Spaces are limited. Register now.
Good afternoon. My name is Jay Rahman, and I am Professor of Urology at Penn State Health and Chair of the AUA's Office of Education. It's my pleasure to do another episode in our educational podcast series, with this episode being one of a few where we highlight some of our annual meeting content. As many of you know, the AUA annual meeting is just about 8 weeks away. And this year we have two fabulous hands-on courses that are actually going to be extending the entire day, and we'll learn a little bit more about them. Today's program is really focusing on one of these courses. It's called The Fundamentals of Prostate MRI and Transperineal Interventions. And our two course directors have really been kind enough to give us a little bit of time today to talk to us about the disease and then where this course really sort of fits into how to address some of the questions we have with prostate cancer diagnostics and obviously the path forward. My guests today are Dr. Arvin George. Dr. George is Associate Professor of Urology at the Johns Hopkins University Hospital. He's the Director of the Prostate Cancer Program, specializing in focal therapy and image-guided prostate interventions, as well as minimally invasive prostate cancer treatments. And Dr. James Wysock is Assistant Professor of Urology at NYU Langone Health. He specializes in a range of prostate cancer diagnostics and treatments, from MRI-guided biopsy, other types of focal and ablative treatments, as well as robotic surgery. So first of all, Arvin, Jim, delighted to have you both. Thank you for sort of carving out some time on a Friday afternoon to talk to me and as well as talk to our listeners.
Thanks for having me. Thanks. My pleasure to be here. Thanks, Jay.
Yeah, likewise. Really excited to highlight this new course offering, I would say. It's kind of a little bit different from prior years, and happy to speak about it today.
So maybe what we'll do is before we dive into the course itself, maybe I'll just, let's start with maybe the 20,000 foot view, which is, why the course, obviously, that'll sort of lend into why we've sort of really expanded it and made it one of our featured hands-on courses. But I think it all has to do with, prostate cancer diagnostics. Why don't we start with that? And maybe you both can talk to me a little bit about, the 20,000 foot view, and then we'll sort of dive into some of the specifics.
Sure. I mean, Arvin, I can go ahead and just start if you don't mind. Look, I think we've been involved, or, Arvin and I both have been involved now for many years with hands-on courses through the AUA to teach prostate fusion biopsy. And really it goes back to about 10 years now when the introduction of MRI as a tool to assess for prostate cancer really became something that urologists could start to utilize. And I think that in order to utilize it effectively, there are many different steps that you have to go through and learning curves that we all have to go through. And it's not really something that was available in standard urologic training at the time, and even still remains a component of training programs that is not fully incorporated in many ways. And there are a lot of practicing urologists who know that they can obtain an MRI, but don't have a lot of the background in it. And I think that because of that, it serves as a real important educational need that we would like to continue to address, even though we've been doing this for many years. And, as being involved in these courses for many years, plenty of people still come to get that type of training. And that is one of the big components that represents a change in prostate cancer diagnostics that's so critically important. And, the other aspect, and I'll let Arvin sort of elaborate on this, is that not only is it the MRI, it's how do we utilize that MRI, and then how do we access the prostate to evaluate an MRI finding. And that's where transperineal component here is also a fairly new and increasing role for our prostate cancer diagnostics.
Yeah, and I think that, gone are the days where we can just rely on a prostate MRI report. I think now it's becoming essential for us to be able to review our own images, similar to if we're looking at a CAT scan for a stone or if we're looking at a CAT scan for a renal mass. We need to start to be able to take ownership of the study like we do. Of course, our radiologists perform them and interpret them, but we need to be able to look at those findings ourselves. And as we transition into the fusion biopsy space, we need to be able to feel proficient in all aspects of that biopsy. So whether that be processing the MRI imaging with segmentation, interpreting it, identifying the same area that the radiologist has identified on those actual images, and even more so if you're performing a visual registration or cognitive biopsy without the assistance of a software-based or hardware-based platform. And as we have evolved into fusion biopsy, how we access the prostate has changed as well. So over the past few years, we're starting to see the rise of transperineal biopsy, and largely as a result of seeing growing antibiotic resistance, fluoroquinolone resistance, which is a problem that we have generated for ourselves. And with one simple tweak, changing our access to the prostate, getting outside of the rectum where the needles do not traverse the rectal wall into the prostate, now we can go through the skin below the scrotum and use novel local anesthetic techniques, novel access guides to be able to reach the prostate in all areas of the prostate, and even better sample some areas that have been traditionally more challenging to biopsy through the transrectal approach. There have been some reservations regarding being able to do it under local anesthetic. Historically, it was a saturation biopsy under general anesthesia. But most of us who have implemented this into our practice, while we do feel that it is certainly slightly more uncomfortable than a transrectal biopsy, it is well tolerated in the clinic, and it can be implemented relatively well easily in most patients.
No, that's great. So maybe let's break down each of those. Let's start maybe with MRI, and let's just talk a little bit about MR imaging and prostate cancer. I think you both highlighted obviously a paradigm change in the evaluation, maybe of men with an elevated PSA, maybe those that are on active surveillance. But talk a little bit perhaps about some of the data, maybe just big picture on yield of biopsies when you're using adjunctive imaging like MRI, whether that's cognitive or software fusion versus our old conventional TRUS PNB or TP biopsy without MRI guidance. So just kind of give us a sense of the why. How much better are we talking about? And then maybe I'll ask you one or two other questions related to that afterwards.
Sure. Well, I guess, to start, blind biopsies, right? Systematic sampling of the gland, 12 cores, 10 cores, whatever your strategy was prior to the introduction of MRI. We all know there were some substantial pitfalls to that strategy. I mean, primarily you have understaging, you have undergrading that occurs, and you actually tend to find a lot of low-grade, low-volume disease. And if you go back to about 10 years ago, a little bit more than 10 years ago, when the PSA screening crisis really came to the forefront, one of the big criticisms of our strategy to try to influence the impact of prostate cancer on men as a public health issue was that the screening was finding disease we probably didn't need to identify and act aggressively to treat. The MRI allowed us, through studies such as the PROMISE trial, the Precision trial, Peter Pinto's work out of NIH, to show us that by introducing a pre-biopsy MRI allows you to identify an area in the prostate that may be more likely to harbor disease that we need to act upon versus disease that may be indolent. And then performing a targeted biopsy enriches the diagnostic pathway. I think that's still an ongoing question in the literature and in our studies, but it did really bring that to the forefront. And so that's why MRI became so important in moving us into a new diagnostic era. But it did introduce, especially for most of us, is how do we actually get a good targeted biopsy? And can we forego the 12-core biopsy? And that's a different question. It's bigger than what our course would really serve to address. But some of those questions, some of those fundamental aspects are part of what I think most practicing urologists are still dealing with today. And the idea is that even though the MRI is out there, it doesn't mean you're getting a quality MRI when you order one. It doesn't mean that you're getting the exact translation to how to turn that into an effective tool for a man. And so I think really those are what we really are continuing to work on, and components of that whole diagnostic pathway still are being refined. And that's really where we're trying to engage the urologic practice community to really embrace this, learn how to do it well, learn what the advantages and disadvantages are. But everyone sort of understands where MRI can improve that diagnostic, but really implementing that is still a challenge.
Yeah, and to add on to that, the actual net benefit that we get from a targeted biopsy over a biopsy without an MRI, if I define that as the diagnosis of additional clinically significant prostate cancer, meaning Gleason 7 prostate cancer or above, that would have otherwise not be detected on the 12-core systematic biopsy, that's about 8 to 15%, depending on the series that you look at. Now, what's more important is, and I think Jim already alluded to this, is that we have historically seen a lot of upgrading on biopsy at the time of radical prostatectomy, meaning that even up to 30% of patients historically will have higher grade disease and would have otherwise been understaged. In the era of fusion biopsy, we know from the TRIO trial that was published in New England Journal of Medicine that with a combined biopsy, doing both the systematic 12-core biopsy in combination with the target, that upgrading to grade group 2 or above is about 6.7%. And looking for upgrading to grade group 3 or above is even lower. Only 3.5% of patients will have higher risk disease than what was identified on the original biopsy if it was 4+3.
And then maybe just to sort of close out, you both have summarized the data very well. To close out the MRI and the context of the MRI discussion, obviously we talk a lot about MRI in maybe a diagnosis screening setting. Jim brought up very nicely a lot of the challenges with the USPSTF recommendations and how to be better or get better at judiciously determining who needs a biopsy and the yield on that. Talk a little bit, if you don't mind, maybe your own practices with the use of MR in your active surveillance population and maybe how that plays a role. And that maybe that'll sort of touch on not only the new diagnoses, but obviously those with an established diagnosis and how you incorporate that into your algorithms.
Sure. So, look, I think first and foremost, a big challenge for an active surveillance pathway is the risk of undergrading a man before putting him on an observational pathway. And if you look at, the rates of undergrading with a blind biopsy, a 12-core biopsy, historically, that could be as high as 30 to 40%. That's a fairly high rate and risk of putting someone on a surveillance pathway. Now, these data are pre-MRI series, but the concept then becomes, look, by having an MRI to ensure that you have no higher risk disease, it then becomes a surrogate for following the man. You don't have to do annual biopsies per se. You can employ the MRI in an annual sense or even a biannual sense if the PSA is relatively stable, and it becomes a tool that's non-invasive, gives you a way to sort of adjust when you might need to biopsy, when something has changed on the imaging. And it just adds to that toolkit for surveillance patients. And I think it's very helpful for also understanding something like their PSA over time. For example, if you're noticing that the MRI in 1 to 2 year time periods has grown by 20 cc's and the PSA has gone up a little bit, you don't worry so much that the PSA has gone up so much that the MRI findings haven't changed, but the PSA density actually has maybe lowered. And you can start to employ this tool in a much broader sense for understanding a man's prostate health over time. And it also can play a role in understanding some of their BPH symptoms and LUTs as well. And so I think the MRI actually stands in for a surrogate in many ways for me in all sorts of prostate management, not just active surveillance in cancer, but even if I've determined they haven't had any cancer, it provides a talking point for discussing some of the other impacts from prostate health, such as BPH.
So Arvin, you talked about this a little bit. So we've talked about imaging, and obviously the MR, at present being sort of a cornerstone of how we can improve prostate imaging, and then obviously diagnostics. And then I think you touched on it, which is so now we visualize better, but now it's a sampling question. And when you talked a little bit about transrectal and transperineal, maybe maybe I'll start with you, Arvin, but to both. Give us a little bit of a sense, and you mentioned, the quinolone-resistant gram-negative organisms, infectious risk. What sort of differences are we talking about? Maybe both with infection, but maybe could you also comment on, is there a difference with diagnostic yield between transrectal and transperineal? And I know there's some new trials that have come out. Maybe you could comment on some of those recent randomized trials as well.
Yeah, from a cancer detection rate perspective, or diagnostic yield perspective, I think the consensus is that when the same number of cores are taken between a transrectal and a transperineal biopsy, that your cancer detection rate is not going to be different. However, I think that many believe that you can do additional sampling with a transperineal biopsy with much more limited morbidity, as you're not puncturing the rectum and introducing potential contamination into the prostate tissue as frequently. And there are a number of different randomized controlled trials that have looked at cancer detection specifically with transperineal and transrectal, and have typically not found significant differences between detection of overall cancer or clinically significant prostate cancer. Now, from a infectious complications perspective, most trials have not been powered to that until most recently. And I would like to give a plug for the online didactic session for this. And while we do have a tremendous amount of hands-on, it's really hard to be able to put all this information together in one place. And you are going to have absolute key opinion leaders who have basically scoured the entire data, all the studies that are relevant to this space, and summarize it for you so that you can really understand it. But a brief preview of what you may see is the results of the PREVENT trial, which was led by Jim Hugh, multi-center trial comparing transperineal to transrectal biopsy. That is the first randomized controlled trial to show a difference in terms of infectious complication rates. Another trial, Pro-PC trial, that was out of Albany, did not show a difference. Slightly smaller trial and also a single surgeon, single site series. And ultimately, the difference is going to be that we don't need to use antibiotics at all. And that was a very high bar that was put forward in the PREVENT trial. It was transrectal biopsies with the use of a rectal swab, so culture-directed antibiotics, as good as we're going to get with transrectal biopsy versus transperineal with nothing. And we actually saw transperineal outperform transrectal biopsy in that setting. Pretty powerful evidence, the highest level of evidence we can achieve to see that. That combined with changes in guidelines, the EAU has already proposed transperineal biopsy as the primary method of biopsy. And that also subsequently will bleed into US guidelines since the PREVENT trial has been published. And we're already seeing changes in CPT codes. So there will be initiation of new codes in January 1st of 2026 for new CPT codes for transperineal biopsy and fusion. So the time to learn about this and take the course is now.
I would agree. I mean, look, the big issue is the approach for transperineal. There makes a lot of sense, right? I don't think you even need to sit back and say, well, I wonder if it's going to be a lower infection rate. I mean, it makes a lot of sense. The European guidelines have basically stipulated that the biopsy should be done transperineal. That sits on the forefront of many urologists' mind. How am I going to get to that transition from a transrectal to a transperineal? We have over 1 million biopsies being performed in the United States every year that are all transrectal. We're trained and we're very fluent and we're very good at doing transrectal biopsies, but we all recognize that sepsis event as a never event, right? That's a terrible outcome for a man, especially when the biopsy is negative. I mean, think about how devastating that can be, and landing someone in an ICU with a diagnostic procedure is really something that we want to avoid. So I think everybody embraces that concept. How can we make this safer? How can we make it better? And the transperineal becomes an avenue for doing so. The question for most of us is, how do we accurately do that? And let's say for many urologists who may have already embraced something such as a fusion targeted biopsy using a transrectal platform, it's then another leap to go to a transperineal targeted approach, a transperineal fusion approach. So you have a few different components that I think our course would really serve to address in providing urologists with a real immersive hands-on experience to try to address these fundamental key learning points. A, how to do a good transperineal approach, and then how to actually make that a transperineal targeted approach, and try to adapt your practice towards that new strategy.
Yeah, I think you both have phrased it very well, and I think that's I think the implementation side is the great challenge right now. I think that's the real benefit for courses like this, which is, as Arvin really shared, and the course is going to have this data. There's very good data on it, but it's how do you practically implement that into practice? And at least at present, the reality is with reimbursement, a biopsy is a biopsy is a biopsy, and so some of this is patient comfort. How can you easily implement this maybe in an office setting for patient comfort? The second is timeliness. How can you do this in a seamless workflow so that a TP biopsy isn't taking twice as long as a TR biopsy, which of course is going to play into the dollars and cents. And then I think the third, Jim, as you alluded to, is integrating, the concept of whether it's cognitive or software registry, but MR guided biopsy into the TP armamentarium. And I think with the data being there, I think the key thing now is being able to have urologists, and that's not at Johns Hopkins, that's not at NYU, that's not at Penn State. It's just urologists in general, which is really who does all these biopsies, implement that into their practices. So talk about, let's sort of use that as a springboard. So let's talk about each about the course a little bit more in detail. Let's start with maybe MR and imaging. And I think Arvin, you said it so well early on, which is
with the different technologies
when we look at stones, when we look at kidney masses,
we want you to be able to
I don't really rely on the
fundamental skills, so that you can use any of these platforms and any of these technologies.
In looking at the image,
so part of that is just like you said, we don't want to rely necessarily on the radiologist report, but like in a kidney, for example, we just want to make sure that there wasn't a duplicated system that we may have missed. We want to make sure that there's nothing in the, maybe in the renal vein that we maybe just did not capture, that when they're looking in different views that we may not have seen. And rather, we want to be able to identify those findings by ourselves. And within our course, you'll have the opportunity to go through a number of different studies under the supervision of an expert reader and highlight the key things that's important for a urologist to know. And that can sometimes be a bit different than what the radiologist needs to know. And it depends on the context of what you're looking for as well. Prior to biopsy, it's going to be identifying the area of suspicion that's noted on the MRI. But prior to treatment, that may be its proximity to the neurovascular bundle, border irregularity that may suggest extracapsular extension and may impact your ability to perform a nerve-sparing procedure, the presence of a median lobe that may impact your ability to do a bladder neck sparing procedure. So we want to get urologists comfortable with all those things that we use in everyday clinical practice to be able to inform the decision-making that we will do for the ultimate treatment.
And to build on that, I mean, those are absolutely excellent points, but what a urologist could really gain some experience with is how to then translate that MRI into something they can utilize. And there's a few critical steps that I think our course will really help address, which really break down what you need to actually do as a urologist to be effective at a fusion biopsy, and not just a fusion biopsy, but beyond. And that is some of the key steps, which we call segmentation, registration. Some of the language around this is urologists hear it, but to actually get into it and get your hands on, learn what it means to segment accurately, learn to segment on an MRI, learn to translate to what the ultrasound looks like. We all are familiar for the most part with the ultrasound segmentation step of a fusion biopsy, but then identifying what are some of the pitfalls there, how actually to make that more accurate, look for inaccuracies, look for intra-procedure markers of accuracy so that your biopsy, when you walk out after taking a targeted biopsy, no matter how you've approached it, you feel, hey, I should have gotten that lesion accurately. So when you get your pathology report back, you have the ability to do your own QA and understand what are you learning from these. And so did something go wrong with one of your targets? Did something go wrong with your segmentation? Was it on the MR side, the ultrasound side? Yeah. And that helps us all learn how to interpret beyond just getting that report. And I think that as urologists embrace this technology, we all really need to, and I stress this to my trainees as well, get in there and do your own segmentations. Get in there and understand when a segmentation is given to you by a radiologist, review it. Maybe they're completely off. And trust me, I see it all the time. But having that skill set and really getting into this course where we're going to kind of get you down into those details so that you can learn how to do that will really is empowering.
So what about, let's switch over. Maybe we talked about MR. So now let's talk about the other side of it, which is transperineal techniques. What are the key points? What are the key things that somebody that attends this course can walk away from? Obviously, no one's going to be, and I don't think the goal is to have somebody be a proficient expert, but hopefully it's enough that somebody has a foundation at the end of the course. So talk to me about what's the attending going to get out of the transperineal technique portion of the course.
Yeah, I think that we really want to be able to reduce the anxiety level and the inertia that's associated with just implementing transperineal biopsy, which we know can be slightly more uncomfortable for the patient, but also any new skill. It's hard to switch from your old ways, and to be able to implement that and changes to your workflow, that can be a challenge. So what we want to do is make it really, really easy. So we will walk through the steps from everything from the equipment that you need to make it easy for you, the patient positioning, how you do the block, and different templates and what you can use to actually access the prostate to get a good sampling under local anesthetic with the patient being comfortable. So we will have different stations that will reinforce those different steps. So ensuring that one focus will be on the actual periprostatic block, which is very different than what we traditionally perform during a transrectal block. We typically perform the periapical triangle block rather than at the base of the prostate between the seminal vesicle and the prostate. But it's actually very intuitive. When you're using a biplanar probe, everything lines up, and so you just have to make sure that the needle floats in the same imaging plane and gets to the point that you need to deliver the local anesthetic. And thankfully, the participants of this course will be able to learn from all the mistakes that we made. Wouldn't necessarily mistakes, but all the learnings that we've been able to accumulate over the past few years to be able to make that an easier biopsy for both the patient, but also the practitioner.
I agree 100%. Look, there's a lot of equipment out there. There's a lot of ways to do a transperineal biopsy. Many urologists may be approached by different vendors with, hey, here's a way to do it this way, do it that way. We don't want to really wed ourselves to any one strategy, but really try to break it down, as Arvin said, into key components of the process, demystify it in many ways because it is demystifiable, but give these fundamental skill sets: positioning, ultrasound interpretation, perineal access approaches. And I think, as Arvin mentioned, and just to highlight, there are multiple block approaches, but make sure that that's very straightforward and give some tool sets to the trainees so they can say, okay, in my practice and in my environment, this way will work best for me. I'm going to go ahead and take that back with me and then start to get over that inertia step, as Arvin said. You get out there and start really employing these techniques, because once you start to do it, your learning curve will be pretty rapid, and you can get into utilizing this pretty readily.
I know a lot of our radiation oncology colleagues more and more, at least at our place, for patients receiving radiotherapy, will ask for fiducial markers and rectal spacing. Is that something that you both will cover in this course, one or the other, or both?
Yeah, thankfully the skill sets are very similar, and some people have, had maybe, let's say, the reverse plunge. They're already doing spacers and offering it within their practices, and so that bridges the transition to transperineal biopsy very well. Especially if you're doing it under local anesthetic, your focus now is just going to be on how you sample the gland, which is very similar skill set. That space is also expanding. We started with some technologies, and we're starting to have more and more technologies available in the space. And again, you're not going to, with this format of the current course, you're not going to be tied to any specific technology. You will develop the fundamental skills to employ any of those technologies. And how we have structured this allows you to get exposure to many technologies, even if you're already committed to a single technology at your institution. And even more so if you're not, it gives you an idea for what may work best for your own individual practice.
So in the last few minutes, maybe I'll do a little quick fire with both of you. I'll start with Jim. I'll ask you maybe top 4 or 5 reasons why an attendee should come to this course. Jim, I'll start with you. Maybe bounce back and forth.
Well, look, I think the bottom line is we all need to have good skill sets in transperineal and fusion biopsies. This is an opportunity for someone, doesn't matter where you stand in your training level or your experience level, to get a higher level of feedback on all of these skill sets. So I think it's immersive, and have the dedicated amount of time to really get your hands on this is a critical component.
Arvin, why should someone attend this course?
Yeah, I think that this new format, I think, lends itself to a really great learning environment. And so we are now focusing on 8 fundamental skills. There will be 8 rotations for the participants that will cover everything from MRI interpretation, segmentation, fusion targeting, ultrasound segmentation, placement of seeds, local anesthetic placement, different needle guides, different prostate sampling. By this one day, while you may not be the world's expert in it, I think that you will feel very comfortable being able to implement this in your practice when you leave the AUA annual meeting.
And I think you both alluded to it, but one of the feedback we've received more and more for hands-on courses is attendees want them to be hands-on. So they don't want to come to a hands-on course and spend half the time or 2/3 of the time in the didactic session. So maybe just talk a little bit about how you're approaching the didactic component. Arvin, I think you mentioned that a little bit, but sort of this premium on the hands-on time being the time being spent, sort of boots on the ground.
Yeah, so we've tried to shift all the didactic portion, so you're not sitting in a stuffy classroom listening to someone giving a lecture at the AUA annual meeting. That's not why you came there. You can do all of that at home, and you can learn from the best of the best in the field, teaching you about the most contemporary data and techniques. And then the day that you're there, you're going to spend that virtually the entire day focused on learning these skills, putting your hands on the equipment. And if your hands are not on the equipment, Dr. Wysock will hold your hand. You can cut that out.
Jim, when is this? When's the course going to be at the annual meeting?
So it's going to be one day before the annual meeting, a full day, just so attendees would have to come in, to do this, give a dedicated day to this to free them up for the rest of the meeting. So it's going to interfere with any of your meeting plans. It's Friday, April 25th, the day before the start of the official AUA. So you'd come into Las Vegas that, the night before, and then we'd have you with us for the entire day. You get all that training and learning, and then you can then take that to the rest of your meeting.
Yeah, and I think just to build off of what Jim said, one of the great things to think about this is, this course is meant to teach you all the fundamentals, expose you to different elements, because it's occurring the day before the annual meeting. I think the attendees have the opportunity to then take advantage of the exhibit hall thereafter. And if there's a certain product that their hospital already has, a certain piece of equipment, then I think they have the opportunity to sort of springboard from your course to maybe something that might be vendor specific, that maybe appeals to them, or maybe is just practical reality of what they have available. So I think we tried to structure this so this course would really, I think, dovetail with what our attendees could perhaps get from the exhibit hall and the rest of the meeting without it sort of competing with it. Jim, Arvin, really delighted that you both could join. I think this course is really exciting. I think the full day format is very innovative, and I think it really does give an opportunity for attendees to walk away with a really solid skill set. And I really appreciate both of your efforts in leading this.
Great. We really thank you so much. And the last thing that I'll say is that this course tends to sell out before AUA every year. Last year, it sold out 4 weeks before. So I believe there's still some slots available. So if you're listening, grab your slot before it's too late. So thank you for having us.
Yeah, thanks for having me, and looking forward to the course. For
our attendees, please just go to AUA2025 to sign up for the course, as well as any of the other material at the annual meeting. If you go to auanet.org/university, we'll certainly have some of the details of some of the material that we covered on the podcast today. Jim and Arvin, I look forward to seeing you in about 8 weeks at the annual meeting. And again, thanks for all your time and all your efforts.
Thanks for having us.